in about 1 minute.
Perfect.
I'm looking for your slides to appear. Am I missing something?
Oh, so I sent them to Ariana this morning. Can I send you a copy real quick, or I can just share my screen?
That's probably going to be your best bet to share your screen.
Share it. Okay.
Yeah, thanks.
Yeah.
Is that all looking okay on your end? Okay. I don't see any slides yet. Are you able to
Oh, yeah, I can share it now.
go ahead and share them? Yeah, that'll be fine. And then we'll get started.
All right. Let's see. Can you see it now?
I can't.
No? Okay.
Yeah, I can't either.
Okay. Oh, here we go.
Oh,
Uh,
there we go.
Us,
okay.
and then maybe expand your screen if you're able to do that in the slideshow mode.
Yes. Let's see. There we go.
Awesome. Thank you.
Yeah.
Great. All right, let's get started. Good morning, everybody. Welcome back to GIM Grand Rounds. This morning, we have Maria Machala, who's a nurse practitioner and instructor in ENT, and she's the director of the Dizziness and Balance Clinic. She went to college at Medical University of South Carolina, and then she got her graduate degree here at University of Colorado. She's going to be speaking with us today about the common issue that we all face in clinic with our patients, which is evaluating individuals with dizziness and vertigo. So very important talk and very glad to have you here with us. So thank you for joining us.
Thank you so much for having me. All right. I'll get started. Okay, so the first thing I want to bring up, this dizziness and balance clinic is new in the past year. I've been working in ENT for 9 years now, specifically in otology and neurotology, so hearing and balance. And I've always seen dizzy patients, but I've really shifted my practice to primarily dizziness in the past couple of years. And now in this new role, the goal is to partner with neurology because so many causes of dizziness are neurologic, and there's a big overlap between ENT and neurology. So a few ways that we're doing this. I have clinic in the neurology clinic twice a month. So I work alongside with the neurologists. And then I have my wonderful team of neurotologists that I work with in clinic every day that I'm there. And then we also have monthly case conferences, and this includes the ENT team, neurology, neuro-ophthalmology, physical therapy, and our audiologists. And then I really would love everyone to join for this educational event. This is in November. And it's going to be all these different specialties coming together, including primary care, Dr. Matt Moles, and emergency medicine. And we're all going to talk about our approach to dizziness and common things that we see. So it'll be really great. It's from 3 to 6. That way you can still be at home in the evening, have your weekend off, and it doesn't cut in too much to the workday. It is free, but we are asking everybody to register. All right, so let's get into it. So the basics, balance, there are 4 components: the inner ear, vision, proprioception, and then how the brain is processing all of this input. So today I'm going to be focusing mostly on the inner ear and central processing. So I'll do a review of the anatomy. The inner ear is just a fluid-filled compartment. It's all continuous with the cochlea here. That's the part for hearing. And then you have the vestibule, the semicircular canals here, and then also the utricle and the saccule. So a little bit more detail. The semicircular canals detect rotation in all the different planes. So at the base of each canal, you have this jelly-like substance. It's called the cupula. And inside that, you have these little hair cells. You can see them protruding up. And so when the head turns, you can think of the head turning here toward the left, the fluid displacement is going to push that cupula and it's going to move the hair cells. And when the hair cells move, that is going to open and close ion channels. And that's what transduces this mechanical stimulus into an electrical signal. And then same thing over here, you have the utricle and the saccule. And these detect gravity. So if you look over here, this is an example of the utricle. You have that jelly-like substance, but also within that, you have the otoconia. These are the calcium carbonate crystals. And the weight of the otoconia here on the hair cells is how you detect gravity. These also detect linear acceleration. So the utricle is oriented horizontally. So when the head moves forward, there's kind of a lag with the otoconia and that jelly-like substance. It kind of bends the hair cells backward and then they catch up. And then the same thing with the saccule, that is oriented vertically. And so that's going to detect vertical acceleration. And then from there, the signals are transmitted to the brainstem via the vestibulocochlear nerve, the eighth cranial nerve, to these vestibular nuclei. And there are multiple of these. And from here, you can get a reflex, 3 different reflexes, which I'll talk about in a minute. Or the signals are then sent on to the cerebellum, the balance part of the brain, movement, coordination, or the thalamus, spatial orientation, motor planning, things like that. So here are the 3 reflexes. The vestibulo-ocular reflex is what helps us to keep our eyes on target when our head is moving. Okay, so when there's damage to the inner ear or the brainstem, you can lose that vestibulo-ocular reflex. The vestibulo-colic reflex is head stabilization. So you think of standing on something that's moving, you're able to keep your head in the same position. And then the vestibulospinal reflex helps us to stay upright. So today we'll focus mostly on the vestibulo-ocular reflex. So what is the epidemiology of dizziness? It's really hard to say. I mean, there are so many different words for dizziness, so many different sensations that people feel. And then if you look at the different studies, the population samples are all very different. So, but a good estimate is as much as 15 to 20% of adults per year will experience some type of dizziness or imbalance. Bottom line is it's super common. Probably don't need to tell you that. So first, I'm going to talk about some of the most common peripheral vestibular disorders that we see, the inner ear. Then I'll move on to central, and then I'll talk about how to evaluate these patients. So this is kind of a general list. I'll have a more comprehensive list at the end of the peripheral vestibular disorders that you can refer back to. I'm going to focus mostly on the ones on the left here, because they're the most common. So we'll start with BPPV, benign paroxysmal positional vertigo. This is the most common cause of true vertigo. The average age of onset is around 50 to 70. If we see it in patients younger than that, there's usually some kind of a history of head trauma or damage to the inner ear. And then with each decade, the incidence is going to increase significantly. And so what happens in BPPV is the otoconia that are supposed to be here on the utricle can kind of break free. Again, it can be age-related changes, damage to the inner ear. And when those are loose, they can migrate into this posterior canal when the head is tilted backward. So the typical, and I would say 95% or more of the time, it's going to be in that posterior canal. Rarely does it go into the horizontal canal, and even more rare is the anterior canal. That's usually with pretty severe head trauma. So typical presentation, the patient will come in saying that they get dizzy anytime they get in and out of bed, they turn over in bed, tilt their head backward or bend forward and stand up. It can also present sometimes as kind of a vague sensation of dizziness or more of a chronic imbalance, especially in elderly patients. There was a study that was done in patients with dizziness and imbalance. A huge percentage of patients had both of these symptoms, and in like 10% of them, there was BPPV that was unidentified, so not a classic presentation. So it's a good idea to check for this for every patient who comes in with dizziness. So we diagnose this with the Dix-Hallpike maneuver. You turn the head 45 degrees. I'm going to play this video. So not all the way to the side, but 45 degrees. You lay the patient back quickly, and you want the head kind of hyperextended over the table. And then you're going to look for a delayed onset nystagmus. Sometimes it's pretty quick, just like a second or two. Sometimes it's as long as 15, sometimes even 30 seconds. So you really want to lay the patient there for a while if you're really suspecting BPPV. So you can see that delayed onset. And then this nystagmus looks like kind of a jiggling, like it's a torsional nystagmus. It kind of looks like the eyes are bouncing. So it's very different than what we see with a horizontal nystagmus or with a vertical nystagmus. So classic would be delayed onset, that jiggling nystagmus, and then it fatigues. Usually it fatigues within like 10, 15 seconds. For some patients, it can be longer. They often, when they're describing it, they feel like it's going on for a long time, like minutes, but it's usually just a few seconds. Okay. I don't know why it's not moving, sorry. There we go, sorry about that. Okay, so then the way we treat this is typically with the Epley maneuver. There are a ton of different maneuvers that you can do, but Epley is the most common. This can be done in clinic. You can send a physical therapy, or you can teach the patient how to do it or give them resources. There are so many online videos that will teach them how to do this that are very effective. The really only complication of this is that the otoconia can migrate into the horizontal canal. This does not happen very often, so it shouldn't stop you from treating the patient. But you'll see this when you do the full Epley maneuver, you sit the patient up, and then you always want to recheck to make sure that you got all the crystals out. So on recheck, either it's going to resolve completely, great, you're done. You're going to see the same kind of torsional bouncing nystagmus, you do another Epley. Or if it goes into the horizontal canal, you're going to see a very like coarse horizontal nystagmus. This means it's in the horizontal canal. What you do is you just sit the patient up really quickly and have them tilt their head forward. The way the canal is oriented, the crystals will just fall out on their own. So that's pretty much it. The problem that we see is if the crystals migrate around that horizontal canal and kind of get stuck, that's usually if you continue to do the treatments even after it's gone into the horizontal canal. So if you see that horizontal nystagmus, just sit the patient up. Okay, Meniere's disease. This is fortunately pretty rare, but it was way overdiagnosed for a long time. Pretty much any vertigo that wasn't BPPV or something else was diagnosed as Meniere's disease. Meniere's disease is characterized by endolymphatic hydrops. So think of like swelling of the inner ear. On postmortem studies, 100% of the patients with Meniere's had hydrops. However, there were patients who did not have any symptoms but still had hydrops. So there's something else that combines with this structural disorder. And the cause of that is unknown. There's a very high association with migraine. A lot of these patients have migraine. And what we've seen in the last few years is that treating migraine can actually help to treat Meniere's disease. So that's definitely gaining popularity. A lot of people are going to migraine management for this. A lot of the triggers are the same. It's really interesting. So this is diagnosed by vertigo that lasts 20 minutes to 12 hours. And it's usually a true, like seeing the room spinning vertigo. And then associated with cochlear symptoms. So the cochlear symptoms would be pressure in the ear, a low tone hearing loss, and then tinnitus. And usually the tinnitus with Meniere's disease is a low frequency. So it's more of a roaring or rushing or humming, not a high pitched ringing that people describe otherwise. So usually all of those symptoms will happen together, and then it'll all stop. Everything will return to normal. Unfortunately, you can go on to develop, have these episodes over and over again, which ultimately leads to a permanent hearing loss and vestibular dysfunction. So treatment for these patients, there are a lot of different things that we do, low salt diet, diuretics, but really these patients need to be referred to ENT and ideally to otology or neurotology. So next up, we have vestibular neuritis and labyrinthitis. This is a presumed viral infection of the inner ear. And so depending on where it is in the nerve, if it just affects the vestibular branch, there won't be any hearing loss, and that's called vestibular neuritis. If there's hearing loss with it, it means it includes the cochlear nerve also, and so you will get a sudden hearing loss with that as well. That's called labyrinthitis. So the vertigo with this, usually sudden onset, no triggers, and the vertigo typically lasts for at least a day, a lot of times a few days. It will gradually improve. And then a lot of times the patient is left with imbalance for several months afterward. Pretty rare, but it does happen, and it can be very similar to like a cerebellar stroke. So I'll get to evaluation of this in a little bit, but one of the main differentiating factors is the presence or absence of the vestibulo-ocular reflex. It's a little counterintuitive. You want to see that absent VOR, that means it's peripheral and less concerning. If the VOR is intact, meaning they can keep their eyes on target when they move their head quickly, that's concerning for a stroke. There are some other findings too. So these patients will prevent, if you see them in the acute phase, you're going to see nystagmus beating away from the affected ear. So like labyrinthitis of the right ear, they have vertigo, they have hearing loss on the right side, you'll see a left beating nystagmus, and you'll see the absent VOR on the right side. If you see them a day or two afterward, you might not really see any nystagmus unless you lay them down. Laying them in different positions can sometimes bring it out, doing a head shaking test, but you might not see it. A lot of times we see them weeks or months after the event, and we diagnose it based on the history and sometimes the exam or test findings. So the treatment for this, in the acute phase, you want to do vestibular suppressants. Meclizine, benzos can work really well. And then nausea medication. There's not really great evidence for oral steroids and antivirals. They're not necessarily going to hurt, but they haven't been shown to be effective. And then a lot of patients will kind of compensate on their own, especially if they're young, healthy, active. But a lot of patients do need physical therapy to help compensate. Even if you lose complete balance function in one ear, the brain can do a pretty good job of using the other ear for balance. Ramsay-Hunt syndrome, this is pretty rare, but just something to be aware of. Similar to labyrinthitis, which is, we assume like a herpes simplex virus, it's unclear. This is the varicella zoster virus, and so you will see lesions in and around the ear. I've seen them in the ear canal, on the eardrum, or can be around the ear. These patients will have facial weakness on that side, and a lot of them do have vertigo and hearing loss. The difference here, even though these are both viral, you do oral steroids and antivirals with Ramsay-Hunt. Okay, superior semicircular canal dehiscence is another rare one, and that causes some like unusual kind of distinctive symptoms. So it's actually a common finding, but to have symptomatic superior semicircular canal dehiscence is actually pretty rare. So you can see over here on the right side, this is a temporal bone CT. This is the superior semicircular canal where the arrow is pointing, and it should have white bony covering over it, but you can see this one doesn't. And so it creates symptoms like pressure in the ear, hearing your voice loudly when you talk, hearing your heart beating in the ear, sensitivity to noise. And the dizziness with this is pressure induced. So coughing, sneezing, Valsalva, plugging the ear canal, doing pneumatic otoscopy. That's called the Henneberg sign. You can actually see some nystagmus. And then noise-induced dizziness. So loud sound will actually trigger brief nystagmus also. The treatment for this is surgery. So you want to refer these patients if you suspect it to ENT. Okay, these are other causes of peripheral vestibular dysfunction. So just really quickly, yes, you can have a vestibular schwannoma that will cause this, but typically we don't see dizziness as the presenting symptom. Sometimes, but usually it's hearing loss or incidental finding. Autoimmune, this will usually cause a bilateral dysfunction, usually sudden, a lot of times with hearing loss too. This is hard to diagnose because there aren't any specific labs. And you want to try and get them in the acute phase. You can see some of those elevated autoimmune markers. The way we kind of diagnose it is if they respond pretty clearly, like pretty significantly to steroids. And then as soon as they come off it, their symptoms come right back. For a lot of these, like a sudden change in vestibular loss, you do the steroids and things will just kind of gradually improve. With this, it gets worse as soon as they're off the steroids. Infectious causes, syphilis and Lyme disease will cause, can cause isolated vertigo and balance dysfunction. West Nile and bacterial meningitis, there are usually other neurologic symptoms, West Nile like encephalitis. Enlarged vestibular aqueduct is pretty rare. It's just a structural problem. It usually causes hearing loss. Ototoxic, these are some of the more common causes of ototoxicity, usually with hearing loss too. It's going to affect both ears. Traumatic, you can have a concussion of the inner ear. We call it labyrinthine concussion. And this is just with a head concussion, whiplash injury, things like that, where the imaging is all normal, but we actually see a vestibular loss. You can have a fracture of the temporal bone and really of the otic capsule. If you fracture the otic capsule, you can get a dead ear. Unfortunately, no hearing, no balance. And then a few genetic disorders, and then perilimb fistula, it was way overdiagnosed. If you hear that, it's kind of controversial. That's usually a sudden change in pressure, like barotrauma, weightlifting, things like that. But it usually happens in surgery. So don't worry about that one too much. Okay, so moving on to central vestibular disorders. There are many different causes. I'm going to focus on the most common ones that we see here on the left side. On the right side, even though these are rare, they're obviously more concerning ones like stroke, MS, cerebellar degeneration, paraneoplastic syndrome, which real quick, paraneoplastic syndrome is, so there's no like tumor or cancer in the brain itself, but it's the chemicals like the antibodies and things like that can affect the cerebellum. So that can cause isolated vertigo. Intracranial hypotension can kind of mimic Meniere's disease. A lot of these other ones will usually have other neurologic signs, but not always. I've seen multiple sclerosis, patients coming in with what sounds like BPPV, but when I do the Dix-Hall-Pike and things like that, their nystagmus looks central. So sometimes that is the first, it's rare, but it does happen. And then move on here to vestibular migraine. So this is one of the ones that I feel most strongly about because it is so common and it is way underdiagnosed. So it was really only, there was criteria just in 2012, so it's a relatively new disorder, even though it's been described for many years. I think what is tricky about it is it often occurs without a headache. So people don't think of migraine unless there's a headache associated. But just like ocular migraine, you can have vestibular migraine. And it's not an aura, so it doesn't last just a short amount of time before the headache. It is a usually prolonged episode of vertigo. So the criteria for this, personal history of migraine, vestibular symptoms for 5 minutes to 72 hours, and at least half of the episodes are associated with at least one of these following symptoms. So headache, migraine, headache, photophobia, I would say, or phonophobia, and then visual aura. It's nice when patients come in with, very clear symptoms, but I would say most of the time, they either have never had a migraine headache, they have maybe a family history, or they have a history of migraine and they don't necessarily have these migraine features with the vertigo, but we've ruled everything else out and treat them with migraine preventatives and they respond. And so that kind of helps us to diagnose it too, even though they don't really meet criteria. The dizziness can really be any description. So it can be true vertigo. They can see the room spin. It can be an internal sensation of vertigo. It can be disequilibrium. They'll describe brain fog, floating, just a lot of weird sensations. So how is this treated? Very similarly to migraine headaches, you want to avoid common triggers. One of the things I really focus on is sleep. So getting enough high quality sleep, and treating sleep apnea. It is really hard to manage these patients unless sleep apnea is treated and unless they're sleeping well. Migraine supplements, these are recommended by the American Headache Society. They're effective in vestibular migraine. Also, it's magnesium, probably the most important, in high dose, like 600 milligrams if they don't have kidney issues. Riboflavin, coenzyme Q10. Migraine prophylaxis, so pretty typical. Migraine headache preventatives as well. There are others, but these are the ones that we use frequently and they seem to work well. Migraine abortives, there's not really good evidence that these actually work. Like triptans haven't really been shown to work in vestibular migraine. I have patients on occasion who benefit from them. Some of the newer ones like Nurtec do seem more promising, but those can be tough with insurance, and again, not a ton of evidence on those. So really, we will initiate migraine prophylaxis a lot sooner in these patients than you would for somebody with migraine headaches. So even if they're only having a couple of episodes a month, since we don't have a really good an abortive medication, we'll start the preventatives. And then you want to give vestibular suppressants for the acute symptoms only. So meclizine or a benzo. And then a really good resource for patients is here, the Association of Migraine Disorders. This was started by an otolaryngologist, so it's got a lot of those ENT, weird atypical migraine symptoms. Okay, so persistent postural perceptual dizziness. This is also one of the most important things because it is extremely common. It was previously referred to as chronic subjective dizziness, but really just described in 2017. So again, a new disorder. There aren't great studies on it, so the prevalence is unknown, but I will just say from experience, it's probably the most common thing that I see. It is a functional disorder, so it's think of it as like central processing. The brain isn't using the information from the inner ears and the eyes and proprioception the way it should. It's typically triggered by a vertigo event. So I think of the way I describe it to patients is the brain stops trusting the inner ears because of the vertigo and starts relying more so on vision. So opposite of what we want. I've also seen it triggered by other things that will cause dizziness, like cardiac event. When they have chronic dizziness after a cardiac event, all cardiac causes are ruled out. It's usually 3PD. And I think a reason it's missed is because it often coexists with other vestibular disorders. So it's overlooked. You see a patient with Meniere's or vestibular migraine, and all their dizziness is attributed to that, but they're having this chronic feeling of dizziness. And this isn't identified and treated. It's also not a psychiatric disorder, even though anxiety and depression are common in these patients, but it's a separate entity. So what it is, it's a chronic feeling of dizziness. So it's present most of the time or most days. It doesn't have to be continuous, and for at least 3 months. It's worsened by being upright and moving, active or passive, and then complex visual input. And this is because, again, the brain isn't using the inner ears as much, it's using vision. So you go into a busy visual environment, think of a grocery store or something like that, it makes patients extremely dizzy. So the treatment for this, physical therapy, and you want to get a really good vestibular therapist. This is not the same treatment that you do for somebody who's had a sudden vestibular loss in 1 ear. It's retraining the brain, again, to use the inner ears and not the eyes. Serotonergic medications are really helpful. And then cognitive behavioral therapy. More resources on this. Jeffrey Saab, he's a leading researcher. He's at the Mayo Clinic. He's a psychiatrist and works with neurologists and neurotologists on this. All right, mal-day debarquement. This is rare, but once you know about it, it's kind of hard to miss. This is a feeling of dizziness that's triggered by being on a boat or a plane or a long car ride, some kind of continuous motion. And then when you get off and you're on land again, everything's still, you still feel like you're rocking or swaying. The difference between this and 3PD is, the triggers are a little different, but also this one is, the patients actually feel better when they're in motion. So they get better when they're in a car or on a plane. The treatment, again, physical therapy and medication. These really, there's not a whole lot of evidence on using medication, but it's something we've done for years here. Carol Foster, who was our dizzy specialist, she did it for years. And then physical therapy hasn't really been shown to be super effective. However, one of the groups here, South Valley PT, they specialize in just dizziness and balance. They're doing a study right now on mal-day debarquement, and it's a novel program. It seems really promising. So,
Can I interrupt you with a question?
yes, please.
There's a question in the chat. You mentioned physical therapy and the importance of getting well-trained vestibular therapists. And the question was whether all of our PTs do this, or what's like, how would you advise us as far as a PT referral?
Yeah, I have that in one of the last slides,
Okay.
just some ways to find vestibular therapists. So I'll go over that. Yes, we do have great vestibular therapists at university. Some of the names, E.J. Gann, Lena Kleinschmidt, Renee King. Usually when we put in a referral for dizziness, it's scheduled with one of them.
Okay.
If it's something like a pretty straightforward BPPV or vestibular neuritis, I just send it on. If it's something more complex like 3PD, I will specify who I want to send the patient to. Okay. We're working with physical therapy. That's kind of part of this dizziness and balance clinic to have a more defined way how to get patients in.
So while we've interrupted you, there's also a question about scopolamine patches,
Yeah.
for Vertigo, or for, are we anticipating a future slide again?
Yes. Yes, I will get to that. It's a great question. All right. So let's talk about how to evaluate these patients. One of the first things I try to do is figure out what type of dizziness they're experiencing, because it can kind of lead you down a specific path of tests and all that. So is it true vertigo? That's the feeling or sensation of movement when there's no movement present. So it can be seeing the room spinning or feeling like you're moving. Disequilibrium is kind of like a floating sensation. Things don't feel connected. Imbalance, I typically think of that as only when somebody's up moving. So it includes the proprioception, vision, all of the parts of balance. So usually when they're seated, they feel better, or laying down, they feel better. And then lightheadedness, of course, you want to think about cardiac causes, stuff like that. Figuring out how long the dizziness is lasting can be very helpful. If it's really short in duration, you think of BPPV, vestibular migraine, or that weird canal dehiscence. If it's hours at a time, the two that I think of are Meniere's and migraine. Days at a time, migraine, not Meniere's. And then if it's a one-time episode, vestibular neuritis or labyrinthitis. If it's constant, you think of 3PD or mal-day debarquement. And then also some of the central causes like cerebellar disease. What are the associated symptoms? Is there hearing loss present? You think of Meniere's disease, especially if it's unilateral. Even though you can have bilateral Meniere's disease, it typically affects just one ear at a time. Earfulness, and this is a really important thing to point out. Earfulness can actually be a sign of hearing loss. Patients will come in and they'll say they feel like they just need to pop their ear, they have fluid in their ear. You look in their ear and there's nothing there. It can actually be a sudden sensory neural hearing loss. So that's really important to identify so that they can get urgent treatment. We do steroids for sudden hearing loss, but don't let them fool you by saying they just need to pop their ear. Tinnitus, it's a very common symptom. So it's really helpful if it's just unilateral, that low rushing humming sound. It's very common in vestibular migraine and a lot of the other disorders. So it can help with Meniere's, but not really a lot of the other things. Are there associated migraine symptoms? And then are there associated neurologic symptoms? triggers, positional, you think BPPV. Migraine can also mimic that. Chiari malformation, actually, I know I don't have that in there, but that can cause dizziness when you lay down. And then also you think intracranial hypotension should improve when they lay down. Spontaneous episodes are usually migraine, sometimes Meniere's, and then labyrinthitis. Pressure changes, you think of canal dehiscence. Noise induced, if it's a really quick dizziness, you think of canal dehiscence. Noise can be a migraine trigger. So if they're having a long episode of dizziness afterward, I think more migraine. And then common migraine triggers. So for the exam, you want to do a really good neurologic exam, casual gait, tandem gait, Romberg, cranial nerve testing. And I really focus on the extraocular movements. Facial weakness, the facial nerve runs right next to the vestibulocochlear nerve and the internal auditory canal. So a mass effect can cause facial weakness, or you think Ramsey-Hunt. The head thrust test, so looking at the vestibulo-ocular reflex, this is also the head impulse test, which I can go over in more detail if needed. And then, one of the things they do in the ER for acute vertigo is the HINTS exam. So that's the head impulse test, nystagmus, which I'll get to in a minute, how to differentiate peripheral versus central. And then the test of skew. So that's covering one eye and having the person fixate. And when you remove and cover the other eye, if there's vertical drifting of the eye that was covered, that would be positive. That's concerning for a central cause. And then always a Dix-Hallpike, even if they're not describing positional symptoms. So for nystagmus, generally speaking, we say horizontal nystagmus is peripheral, and vertical or torsional, with the exception of BPPV, would be central. For peripheral, it will typically decrease with fixation. So eyes open in the light, looking at something will get better. When we remove that fixation, like we'll put infrared goggles on the patient so they can't see anything, it will usually increase with peripheral. Different than central. It'll increase, and if you remove that fixation, it can decrease. With peripheral, generally speaking, it's direction fixed. So it's always going to be the same direction. And it's usually away from the site of the lesion, with the exception of Meniere's disease. That's an excitatory lesion. You can have nystagmus beating toward that ear. And then central can be direction changing, usually gaze evoked. So gaze left, left beating, gaze right, right beating, gaze up, up beating. You can have periodic alternating nystagmus, pretty rare, but that would definitely be a central sign. And that's just spontaneous change of direction. So some of the tests that we do, usually an audiogram, don't do it if it's BPPV or if the patient really doesn't have any cochlear symptoms. Video nystagmography, that's done by our audiologist, and it tests the balance function of the inner ears. I have a slide on that. I can go over that in a little more detail. In MRI, I don't always get, definitely if there's an abnormal neuroexam or asymmetrical hearing loss, or if you've kind of ruled out any other peripheral cause and you just can't figure out what's going on, definitely an MRI. And then CTs aren't really helpful, I mean, unless, in the acute phase and you're looking for a stroke, but really, if it's this chronic dizziness, I only get it if I am looking for canal dehiscence. So our video nystagmography, we can test the function of the semicircular canals, the otolith organs, the VOR. It's much more sensitive than just the head thrust test. And you can actually test it in all the different planes. So you're looking at all the semicircular canals. We stimulate our nystagmus with hot and cold water in the ear. So just one ear at a time will activate that inner ear and cause vertigo. That's a good thing. So we look at a normal response and if there's a difference between the ears. Vent testing, not a great test to see if there's really been damage to the inner ear. We use that more for diagnosing canal dehiscence. VOR, and then we look at oculomotor findings like smooth pursuit, saccades, things like that. And then much more sensitive for positional nystagmus. Again, we're doing it in the dark so we can remove fixation. Okay, so I don't have scopolamine on here, but I will include it. Vestibular suppressants are overused for dizziness. They can be really wonderful in the acute phase when the person is having true vertigo. They should never be used for more than, I would say, a day or two. because once you're out of that acute phase and you go into compensation. And if you're suppressing the vestibular system, you're not going to compensate well. So it leads to a prolonged course of recovery. And then when you're chronically suppressing the vestibular system, your brain's going to use your eyes more. It can lead to that persistent postural perceptual dizziness. It's also, these medications take a while to kick in. So if the episodes are only lasting minutes at a time, or 15, 20, 30 minutes, it's probably not going to be that helpful anyway. So you can use these, but just with caution. They're wonderful medications for patients who have Meniere's disease, like prolonged hours-long episodes, or even vestibular migraine. Great in vestibular neuritis, again, for just a day or two, and that's it. And then physical therapy. This is one of the most important tools for treating many types of dizziness. It's not useful if there's spontaneous dizziness, because they're not going to be able to really fix the trigger. You kind of have to wait till the episode's over. It is good for more of a chronic feeling of dizziness or imbalance. So you can refer for BPPV for maneuvers to help recover from vestibular neuritis. Can be useful in Meniere's or vestibular migraine if there's imbalance in between the episodes. And then, of course, for chronic dizziness and chronic multisensory imbalance. So maybe their inner ears are fine, but they don't have good binocular vision, or they have problems with proprioception. Very appropriate there. So finding a vestibular physical therapist, again, we're kind of working on a pathway here in our system, but you can refer to the Vestibular Disorders Association. This is great for vestibular therapists, but also any kind of vestibular provider, so neurologists, neuro-otologists, all over the country. And then the Academy of Neurologic Physical Therapy, there's a special interest group for vestibular patients. Before I go into that, are there any other questions?
I have one. So your video of where you were doing the Dix-Hallpike, and it looked like you had a pair of goggles on to monitor the nystagmus. I know that I struggle often to do a Dix-Hallpike, and often the patients, they're closing their eyes, and you get a few beats of nystagmus, and so I'm not always confident it's torsional or horizontal. Do you have any tips for that?
Yes, I totally agree. It can be very, very difficult. So a few things. I try and explain the procedure really well to the patient beforehand, say this might cause really severe vertigo, but you need to keep your eyes open. I can't do this unless you really keep your eyes open. So that kind of helps. The other thing is, when I'm looking, it can be very subtle. So I try and pick either a point in the iris or like one of the little blood vessels and close to the eyelid. And so you can see a lot more subtle movement if you're looking at those little blood vessels. So that can help. Sometimes I can't tell the direction of the nystagmus. So if I can't, if it fatigues, then I think it's probably BPPV. And then if I'm not sure, I'll check both sides. And if they are symptomatic on one side, I'll treat it even if I'm not seeing anything. If they're symptomatic on both sides, it is very rare to have bilateral BPPV at the same time. It happens occasionally, but if they're symptomatic on both sides and you're not really seeing obvious nystagmus, it's not BPPV.
Thanks.
Of course.
I have
All
a
right.
question or two, possibly. And so one is, what do you do with a negative Dix-Hallpike and somebody who seems for all the world to have BPPV? Am I misinterpreting the negative? Like, I just didn't wait long enough for the nystagmus to show up? Because I feel like there are people who have just very typical positional vertigo, seeming like there's just nothing else it could be, and I do the Dix-Hallpike and it's totally normal. Or they
Yeah.
get a little bit dizzy and they have no nystagmus, and I go, I just don't believe the test. Is that bad care? And then the other
No.
question is, in terms of vestibular rehab, do we have vestibular rehab experts at the university, or do I have to do something with this Vestibular Disorders Association?
So there are a couple who have a lot of experience treating vestibular disorders. So EJ Gann is one of them, Gann. Lena Kleinschmidt is really good, and then Renee King. So those are the few I would say are physical therapy department is really good about getting patients into them who need to be seen by them. But again, we're working on a pathway here at the university. There are other groups in town who just specialize in vestibular disorders, like South Valley PT and some others. Sometimes it just depends on the location of the patient, and how quickly they can get in. But if they don't respond to physical therapy and they're doing it with a general therapist, sometimes I will recommend that they go to one of these really specialized groups. And then back to the BPPV question, it can be really tricky. I agree. Sometimes I am just so convinced that the patient has it, but I don't see anything on exam. So for those patients, I will hold them down longer and see, for a minute even, which seems like forever. Sometimes I'll do mastoid vibration, or even just tapping on the mastoid bone when you're doing it can help to kind of loosen those otoconia. And then if you're still not seeing anything, sometimes I'll send the patient home with exercises to do on their own. I just say, do these a couple times a day for a few days and see what happens. And if they respond, great. If they don't, then I do start to get concerned about a central cause, which could lead to positional dizziness. In that case, I will do a VNG. And then if we're still not seeing any nystagmus, it kind of depends. I may or may not get an MRI. And that depends on what other symptoms they have, what other risk factors they have, things like that, how severe the dizziness is. So I hope that helps.
Thank you.
All right. So go on to a little case study here. So 62-year-old female comes in with, she has a history of migraine, anxiety, and sleep disorder. She's presenting with a chronic feeling of dizziness, and it worsens with position changes. And this all started years ago after a prolonged episode of true vertigo lasting over a day. So the way I approach these patients, I always go back to the beginning. Tell me all about the first episode that you had. What were you doing? Were there any triggers? What associated symptoms did you have? Did you actually see the room spinning, or describe the dizziness a little more? So for her, she was just sitting, scrolling on her computer, and she did see the room spinning. She was very nauseous, but no other symptoms that she could recall. And then I go on to the chronic dizziness. Is it most of the time? What makes it better or worse? She feels it most of the day, but she will have some good days here and there, and go brief periods without it. She does feel better sitting, but sometimes she will feel dizzy even if she's sitting or lying down. Any associated cochlear symptoms? She gets tinnitus bilaterally, intermittently. Most people do, so that doesn't help necessarily. Any associated migraine symptoms? She gets intermittent light sensitivity, but doesn't necessarily correlate with dizziness. And then go on to the positional dizziness. Are you seeing the room spinning? Is it more of a feeling, and how long does it last? She feels like everything's spinning for several minutes. So you start to think of some differentials. You do the exam, everything's normal, so normal neuro exam. Orthostatic vitals are normal. I always check those on positional dizziness, even if they're describing true vertigo. You don't see any spontaneous or positional nystagmus. The extraocular movements are intact. Head thrust test is normal. What does this tell me? So when I'm thinking about that prolonged episode of vertigo, maybe she had a loss of balance function. Maybe she didn't. If she did, she's compensated for it. And we can tell that she's not in the acute phase. She's compensated because the head thrust test is normal and there's no nystagmus. There's no positional nystagmus. The Dix-Hallpike is negative. So then I ask, well, when was the last time you had it? A lot of times BPPV will just resolve on its own. So if they haven't had it in a few days or a few weeks, then it's probably resolved. If they say I had it last night or this morning and you still are not seeing anything, that's when I think, could this be something else, or am I just not giving it long enough? So after all that, my primary differentials are she had an initial episode of vestibular neuritis. When you have damage to the inner ear, you're at higher risk for BPPV, so it's common after vestibular neuritis. And then this chronic dizziness would be 3PD. I also think because of her history of migraine, and because I didn't see a positive Dix-Hallpike, she might fit criteria for that too. It's a little iffy. The light sensitivity doesn't necessarily correlate. However, it might explain this positional dizziness with an absent Dix-Hall pike. Because again, lasting a few minutes at a time, she's not necessarily seeing the room spinning. But then also, either way, she's got 3PD. So from here, I'll get a hearing test. She doesn't really have any cochlear symptoms. She has tinnitus, but it's part of the full workup. The balance testing to see if there's been any balance dysfunction. I don't always do this, to be honest, if I don't see anything in clinic, but it can sometimes help the physical therapist to know if there's true vestibular dysfunction and if they need to focus on that or just the 3PD. And then when it's unclear, an MRI, I would send her home with the information on how to do these repositioning maneuvers to see if it helps. I would send a PT either way for 3PD, and they can also evaluate for BPPV if they happen to catch it when it's happening. I'd have her follow up in 2 months. If there's no improvement, that's when I would start a medication for this 3PD. The one that I choose in patients who have a history of migraine, whether or not, if it's questionable they have vestibular migraine, is Effexor. It's because it's an SSR, or it's an SNRI, so we know it's helpful in 3PD. And of the SSRIs and SNRIs, it's the only migraine preventative, really. So that's it. And I would love to see everybody at this dizziness event in November. So any other questions?
I've got one again. Can you describe the head thrust test? That's not one I'm familiar with.
Yes. So this is again to test the vestibulo-ocular reflex. So the way I test it, I turn the patient's head slightly to one side. So if you look at mine, I'm going to turn slightly to the left. I'm going to tell the patient to look at my nose, keep their eyes on my nose, and I'm going to move their head quickly. You want to ask if they have any neck problems, because it is a quick movement. So I turn slightly to the left, but really I'm checking the right side. So I'm going to move quickly to the right, and they should be able to keep their eyes on target. Now, if you turn quickly to the right and the eyes move with the head and then bounce back, that's called a refixation saccade or catch-up saccade. And that's a sign of an absent vestibulo-ocular reflex. So again, acute damage to the inner ear, much less likely a brainstem lesion without any other brainstem symptoms. So really that's kind of how we differentiate between like labyrinthitis, if it's peripheral, or a cerebellar stroke, which you might not have any other symptoms. It could just be isolated vertigo. So.
And you do it both ways. So
Do it
you
both
have,
ways.
okay.
Yeah, the reason I don't start from the middle and go over to the right side is because, you tend to have a few beats of that end gaze nystagmus. So if you go too quickly to the side, you're going to get that in a normal patient. That's why you want to start, kind of turn to the side, and then come more towards midline a little bit over, so that you're not getting that and you're getting if it's a true refixation saccade.
Thanks.
There's a question in the chat about handouts or educational materials for the home exercises. Dr. Overholzer, I presume you mean the Epley maneuver in this case. I know that there's one on UpToDate that I like. Is that the one that you use, or do you use a different one? I know Carol Foster has a YouTube video. I sometimes send people that. Do you like that? Are there others that you think are good?
I've watched so many of the videos and I don't really have a problem with any of them. So I don't necessarily recommend a specific one. Of course, I do like the half somersault maneuver. That is a great one because patients can do it a little bit easier than they can an Epley maneuver. But really, you can just Google Epley half somersault and the videos are great. They usually walk patients through very easily. So we're working, that's another thing we're doing, trying to revamp our dizziness and balance website with resources like that. So I can send that out. I guess I can email you and you can send it to everybody. But our new dizziness and balance website will have some of those resources on there.
Great. Any other questions from the group? If you'd like to speak up, go ahead, or if you'd like to send them through the chat, that'd be fine too.
And please feel free to email me with any questions. Another thing that has changed, you may have noticed when you refer a patient for dizziness before, even if you sent them to neurology, they would automatically go to ENT. It's not appropriate. I don't want to undermine anybody's clinical judgment or what you're seeing in clinic. And so if you refer to neurology, they're going to go to neurology. If you refer to ENT, they're going to go to ENT. You may also have noticed that the wait time to get into ENT is much quicker. And so if you want the patient to be seen quicker, you can refer to ENT if it's unknown. If it's obviously neuro and you need them to be seen quickly, of course, you want to do an urgent referral. Either way, we have much better communication now between ENT and neurology. So these patients are either going to get to see us both pretty quickly. We have ways to get patients back and forth, or they're going to be discussed at one of the case conferences. So,
and is there a separate referral for the balance clinic you mentioned in the first slide?
no. And it's not, this is just kind of something we're working on. There's no like specific pathway now. But again, you can refer to ENT or neurology, and most likely it's going to go back and forth between us.
Okay. So a referral to ENT with the diagnosis of dizziness or vertigo, and that gets there. Is that okay?
Yes. Now, if there are neurologic symptoms, stuff, then it's probably not inner ear. Definitely send them to neuro first.
There's actually another question in the chat. You mentioned avoiding meclizine for long-term use. Do you counsel patients against the use of other antihistamines as well?
I typically don't see that. And not the ones that are used for, like Zyrtec and all those. We don't have a problem with those. The sedating ones, most people aren't taking those on a regular basis anyway. I mean, if they're taking it nightly for sleep, then that could affect it. I just don't see it as much. So, but the big problem I see is people are sent home on meclizine and they don't realize they stopped taking it and they're taking it 3 times a day for months.
Okay, that looks like all the questions. Thank you so much for that presentation. This is really a common and challenging issue, and that was very helpful. So I appreciate that.
Yeah, thank you so much for having me.
Yes, I'll add my thanks to that and note that there are similar thanks in the chat. So thank you so much for taking the time to be with us.
Absolutely. Thank you.
Have a good day, everybody.